Welcome for another session. And today I'll be talking about MRI changes in acute ischemic stroke. And then we'll look at some of the lesser known facts about the same. So let me share my screen. So I think you're able to see the screen now. So our topic, as I said, there are lesser known facts about MRI and acute ischemic stroke. And the most classical finding what we see in MRI in acute ischemic stroke is hyperintensity on diffusion weighted images, also known as DWI, and hypointensity on apparent diffusion coefficient, that is ADC maps. So when we have combination of these two findings, it is suggestive of acute ischemic stroke or infarct, acute infarct on the brain, and it is the most specific finding. So just to see how it looks, on the left, there is DWI image. You can see the whitish areas, that is the ischemic or infarcted tissue. The same area will be seen darker color, that is hypo intense on the ADC maps. So this combination, hyper intense on diffusion and hypo intense on ADC maps, it is suggestive of acute infarct. The next point is how long can these MRI changes last? So usually what is known is that hyperintensity on diffusion and hypointensity on ADC maps, they can last up to about 2 weeks after stroke, and after that they disappear. But in one study done about 16 years back, hyperintensity on diffusion persisted in almost 64% of patients at the end of 1 month. So it, even though it's usually 2 weeks, but many patients hyperintensity can last up to 1 month also. And these are the patients who had more severe initial strokes based on the NIH stroke scale. And also they had poorer outcome at the end of 90 days. And what is the record for this longest lasting MRI changes? So that is 8 months. So not 2 weeks, not 1 month, but in rare cases, hyperintensity on diffusion weighted images can last up to 8 months after the diagnosis of stroke. When the ADC values are low on the MRI, it usually indicates that the infarct is less than 10 days old. So low ADC values and hyperintensity, they are the classical features in MRI in acute infarct, but in some cases they can last much longer. But now the other opposite view, can the diffusion weighted images MRI be normal in acute ischemic stroke? Answer is yes, but not in too many. It can be normal in about 6.8%. So, 1 out of 15, it can be negative. And if you look at what are the cases there where the MRI can be negative, these are the posterior circulation strokes or infarcts. So they are 5 times more likely to be diffusion weighted imaging negative as compared to the anterior circulation infarcts. And other condition is the brainstem infarction, where 57% of patients can be diffusion negative if the MRI is obtained within the first 24 hours. But the MRI done at the end of 127 hours or after 5 days, it shows infarcts in all the patients. So just beware that, diffusion weighted can be normal. So if you suspect a stroke clinically, and if CT scan MRI both are normal, you can still go ahead and thrombolize the patient. Then other condition is reverse discrepancy between CT and MRI. So what we mean by this term is that the ischemic lesion is seen on the CT but not on the MRI. On the CT, as you know, infarcts are seen as hypodensity or hypoattenuation, and on the MRI, hyperintensity or DWI. So this kind of situation where CT shows the infarct but MRI is negative, it is called reverse discrepancy and can occur in about 13% of all acute infarcts. Most commonly, they are seen in the infarcts of basal ganglia. But later on, if you follow these patients, MRI changes can occur in all of them at a later date. The last point I would like to highlight about MRI and acute infarct is the diffusion-perfusion mismatch. This is very useful to select patients for thrombolysis in patients who are more than 4.5 hours after the onset of symptoms, or those who are wake-up strokes, because we are not very sure how much tissue is salvageable. So you do diffusion and perfusion. Diffusion shows the infarcted core, where we can see in this red color, and then this is the area, and the perfusion shows the entire tissue which is at the risk of getting infarcted. It is ischemic but not yet infarcted. So you can imagine, if you subtract this part, the red part, from the blue, that part is the one which is the mismatch area, and that is the area which can be potentially salvaged if we treat the patient with thrombectomy or thrombolysis. So I hope with this you have learned few useful things about MRI changes in acute ischemic stroke, and I'd be happy to listen to your feedback, any comments or queries. Thank you. Have a good day.